Welcome, and thank you for joining Westmed's Prostate Health MEDTalk, hosted by Doctors Judd Boczko and Bryan Blair. We're going to get started, but just a reminder to please keep yourself muted and your camera turned off. You can type questions into the chat box for the Q&A at the end. To access the chat box, you can hover your mouse over the bottom of your Zoom screen. If you click on the chat icon, you'll see the chat box open and you can submit your questions there. Thank you, and now I'm going to turn it over to Dr. Bryan Blair and Judd Boczko.
Thank you, Ciara. Welcome everybody to, I guess, our second annual talk on BPH and prostate health. We're excited that we have a lot of people joining us. Some of us are patients of ours already. Some are new to us. Hopefully we can answer a lot of people's questions and educate people about prostate health overall. And we appreciate everyone taking the time out to join us. Dr. Blair is my partner over here at Westmed. And
hello, everybody. Can you hear me?
I can hear you.
All right.
So the two of us urologists over here at Westmed, we have practices over in Yonkers and White Plains and Rye and New Rochelle, and the procedures we talk about and the evaluations we talk about, we both do and do on a regular basis. And again, hopefully this is educational for everybody. Okay, next slide, please. So in urology, sometimes, we get a little stressed out, so a little bit of humor is always good. So if anybody can see it, it says urology department, can you hold? And everyone's laughing because obviously everyone understands that joke. Next slide, please. Okay, so just to understand this general anatomy, look at the picture on the right side of the screen. It shows a body like cut in half looking from a side view. And on the right side, you'll see the bladder. It's that balloon-looking organ, and then right below it is the prostate, which is that peach-looking organ. And what you can see from that is that the urine goes from the bladder right through the prostate and then goes through the rest of the urethra and the penis. And as you can see from that, it's not a tube but a tube. People often mistaken thinking that the urethra and the prostate is like a straw within the prostate. But in reality, the inside of the prostate is just hollow, and it just is a continuous channel from the bladder through the prostate and out. The rectum is behind it. That's the cylindrical organ to the left of that. And that's why when we do a rectal exam, we can feel through the rectum the backside of the prostate, which is really more of a cancer screening exam than anything else. Next slide, please. Okay, in terms of enlarged prostate, in terms of prostate conditions, there are three general prostate conditions. Enlarged prostate, what we call BPH, prostatitis, and prostate cancer. Each one of these conditions affects the prostate differently. And we're going to mainly speak about BPH, enlarged prostate today. I will just touch base a little bit on the latter two. Next, please. Something's off on the slides. Unless it's just my computer, but.
No, it's off.
It looks like one slide is overlaying the other slide. There we go. So prostatitis is a fancy way of saying inflammation of some sort in the prostate gland itself. Generally, it comes up as more like pelvic pain, pain in the testicles, pain underneath the testicles. And there are three versions. There's bacterial, viral, and neither, which we'll call CPP, chronic pelvic pain. They all kind of seem similar in terms of the way they cause symptoms. Bacterial prostatitis actually is only about 5% of all cases, and that's where antibiotics work. A lot of people do throw antibiotics at the disease, but in reality, unless you have bacterial prostatitis, antibiotics are not going to do much, and just use anti-inflammatories and conservative therapy. It's a frustrating condition because of this. It's actually quite symptomatic in patients where they get a lot of pain and discomfort, but the problem with prostatitis is there's really no magical cure or remedy for it, and we really treat the symptoms as opposed to anything else. Okay, prostate cancer. Again, that's not the focus, but of course we would be remiss if we didn't talk about it at all. So prostate cancer is the #1 newly diagnosed cancer in men. It's the second leading cause of death in men. In 2019, about 175,000 men were diagnosed, and over 30,000 men were expected to die as a result of prostate cancer. The probability of cancer increases with age. So you see from 40 to 60, we say it's 1 in about 100, and then as you go to that 60 to 80 group, it's 1 in 8. There are higher rates in African Americans. There are also sometimes more aggressive cancers in African Americans. There are also higher rates in men with primary family members, brothers or fathers that have prostate cancer. It does not mean that you yourself will get it, just means you're at a higher risk of developing it. And in general, about 1 in 41 men will die from prostate cancer. Next slide, please. So this is a good old slide that I've had for years, and most people in this age group that we're talking to know all the guys who are on this slide. And these are just famous men that have had prostate cancer. It's so common that, you know, most people have a family member or a good friend or someone they know of, maybe at work, who've had prostate cancer. And it's something that everyone should know about. Next slide. So some sobering facts are, there was a government recommendation at one point to basically stop screening of prostate cancer, and the American Urological Association really came out against it. And the reason for that is what happened afterwards, which was initially when everyone had screening, about 4% of cases were found at an advanced, almost metastatic spread point in the disease. And, you know, and it involves basically just a PSA blood test and a rectal exam. And you do need a rectal exam besides the PSA because some men have prostate cancer with normal exams. Some people have prostate cancer with normal PSAs, but we catch it via exam. And then in terms of PSA, there's a lot of misinformation online about it. There are a lot of variables of PSA, what we call age-adjusted PSA, which is PSA related to age, PSA velocity, which is where the PSA changes year to year, something called a free PSA, which is a subform of the PSA. And you have to look at all these facts when you kind of evaluate someone for cancer, or a cancer risk, I should say. Next slide, please. So what happened was when they stopped recommending screening, the percentage of patients basically doubled who were found to have metastatic prostate cancer at the time of diagnosis from 4% to 8%. And so since that point in time, they went back to, of course, recommending screening. And of course, we as urologists would always recommend screening, again, when appropriate. It might not be appropriate for every person, depending on their age and comorbidities, and that's something that a person should speak to their internist about or their urologist about. Next slide, please. Just in general, again, we're not going to go in depth in this, but just treatment options for prostate cancer involve what we call a prostatectomy, which is to remove the entire prostate, generally done via robotic surgery. There's radiation with different forms of radiation. You know, people hear about this thing called CyberKnife on the radio or on TV. CyberKnife is just radiation. It's actually one of 4 or 5 different machines that perform something called SBRT, which is just a shorter version of the radiation, but it still is what we call external beam radiation. New for 2021 is a procedure that was actually FDA approved back in 2017. It's finally got an insurance code called HIFU, which uses ultrasound energy to destroy prostate cells. And what it does, different than radiation and surgery, is it allows you to treat just half the prostate or a certain section of the prostate, leaving the rest of the prostate alone, thereby hopefully reducing the risk of erectile dysfunction. Next slide. And then Dr. Blair, you're going to take over from this point for over here.
All right. So we started off talking about 2 of the things that go wrong in the prostate that Dr. Boczko went over, which are infection or prostatitis and prostate cancer. But the other big category, and really most of what tonight's talk is geared towards, is BPH. And BPH is the acronym that we use to describe an enlarged prostate, blocking that channel running through the prostate that Dr. Boczko showed on that anatomy slide. And it stands for benign prostatic hyperplasia, which is just benign as opposed to cancer. And prostatic, referring to the prostate, hyperplasia refers to the fact that there's an increased number of cells. We're going to talk about this uncontrolled growth that the prostate undergoes later on. But that's what BPH means. That's the acronym that we use to describe enlargement of the prostate. And this slide here shows some of the symptoms that occur when the prostate enlarges. And the symptoms are all basically a manifestation of the fact that as the prostate gets bigger and blocks the channel running through the center of the prostate, the bladder tries to compensate. And at first the bladder squeezes harder, and that's a good thing. It gets the urine out and keeps people from going into renal failure. But over time, the high pressures can cause problems, incomplete emptying of the bladder, residual urine left behind, peeing in Morse code, as we say, eventually damage to the bladder and damage to the kidneys. So some of the symptoms you see here on the slide, increased frequency of urination occurs when people start to empty incompletely. It's like lifting a heavy weight at the gym. You can't do 20 reps. The bladder's squeezing so hard, it only gets a portion of the bladder volume out. And as a result, there's a large residual urine in there, so you have to go more often. The stream is weaker because the bladder's squeezing so hard, there's increased resistance in the prostate, so people will have weak or decreased force and caliber of their stream. There'll be a lot of starting and stopping because as the bladder tires, it sort of lets up its tension and then it regains its strength. And so you're kind of getting that Morse code effect that I mentioned. Waking up at night, what will happen is you only get 50% of the bladder volume out when you go to the bathroom, so it doesn't take long before you're full again. And so when you get up multiple times at night, that leads to quality of life issues where you're not well rested the next day and you don't get the delta sleep that you need. And urgency, the bladder becomes a little bit like Jesse James. When it's working harder, it wants to shoot first and ask questions later. And many men, as they get older, they recognize when they got to go, they got to go. They got to run to get there. And it's, it's like a liftoff. It's 10, 9, 8. And so also the high pressures can cause pain. And sometimes Dr. Boczko talked about the infection, which will cause burning when you urinate. So these are all symptoms. Next slide, please. This slide is referring to the fact that this process of BPH is very much age dependent. The prostate it really kind of behaves itself until you get into your, say, 50s and 60s. Most people, the prostate it doesn't get much bigger until it gets to the point where it gets this uncontrolled growth. And men, by the time they're in their 60s, 70% of men are going to have a problem with an enlarged prostate. It's almost all men by the time they're in their 80s. And certainly there are things that can make it worse. Caffeine and alcohol and spicy foods, certain dietary indiscretions can make the prostate symptoms worse in younger men. But this slide refers to the fact that as men get older, it's this enlargement, it's ubiquitous. Everybody gets it sooner or later. It's kind of like death and taxes. It's going to happen if you live long enough. Next slide. So this is a graph that kind of shows that incidence with age a little bit more. It's about 40% of men in their 50s have a problem with this enlargement. About 70% of men are going to have it when they're in their 60s, and nearly 90% of men have it by the time they're in their 80s. Next slide. So you may ask, well, why does this happen? This doesn't make sense, right? Why should the prostate, it seems like a design flaw from our creator that we have an organ that the urine has to go through and it's getting bigger and causing mechanical obstruction. And you're right, it is a bit of a design flaw. What happens is testosterone is a hormone that peaks around age 25, and then it starts to kind of plateau and ultimately falls off a cliff, usually in our 60s, but sometimes earlier. As that testosterone drops, the prostate has a lot of receptors for testosterone. It develops changes in the receptors and changes in your hormone concentrations. And there's an interplay of hormones and receptors. Some of it is influenced by genetics, who your parents are. And ultimately, it results in this uncontrolled, relentless growth that eventually causes problems with urinating that we're kind of going to get into in a minute. Next slide. So this is kind of a picture of the normal state of affairs on the left side you see this red round structure. That's a normal bladder. The first image is what we call a coronal section, as if you kind of cut me through my ears and you're looking at that bladder. And you see there's a nice channel going through the yellow organ underneath it, which is the prostate. The urethra is not compromised. The next image over is what we call a sagittal section. If you cut me through my nose and look in sideways, again, you can see that the bladder looks thin-walled and healthy. There's a nice channel running through the prostate. And then the next picture over is a coronal section, again, cut through the ears of someone who's suffering from severe BPH. You can see the bladder wall is thickened. The reddish structure is thicker in this picture. And then there's these little bands on the inside. I don't have a pointer, but if you look, you can see, looks like little worms. Those are called trabeculations. When the bladder squeezes harder, we mentioned that it's compensatory good in the short term and decompensatory bad in the long term, because the thickened bladder wall, it loses its compliance, its ability to store urine at low pressure, which is important. It loses that, which could ultimately lead to damage to the bladder and damage to the kidneys, and you get incomplete emptying of the bladder. And you can see the prostate below is the cause, meaning that channel is narrowed, and that's what's resulting in this damage to the bladder. You can also see it in the sagittal, or the picture. You cut me through the nose there, that's furthest to the right. One little corollary here is that there's not a lot of black and white cookie cutter rules. In other words, there are some really big prostates that grow outwards and never really block the flow of urine, even though they're very, very big. And then there's some really small prostates that grow inward and cause tremendous obstruction and damage, even though they're relatively small. And to make things even more confusing, there are some people that have significant obstruction, but the bladder is compensated and squeezing harder, and their symptoms don't really bother them. And there's some people that have a little bit of obstruction, and they are light sleepers, or they can't get a good night's sleep and can't function the next day. And even though their obstruction is relatively mild, the bother from those symptoms is severe. So one of the things that Dr. Boczko and I like to continue to point out is that we really try to customize the treatment to each patient. Each patient is a little bit different. Each prostate is a little bit different. Each bladder is a little bit different. And some of these subtleties make a big difference in how we manage the problem. Next slide. So I wanted to emphasize here in this slide, this is kind of another picture similar to the one you saw. The picture over on the right here, this is sort of like the form fruste, or the very worst case scenario. You can see that there's almost no channel at all in the prostate underlying this thickened, enlarged bladder. And there's a lot of white in there. That's scar tissue. That's a bladder that's losing its ability to contract. And the big blue writing underneath says that not treating an enlarged prostate can lead to bladder deterioration. So there's a lot of things, what we call silent prostatism or silent BPH, that ultimately we really want to avoid. In the worst case scenario, you can get a bladder that stops working and someone has to wear a catheter for the rest of their life, or kidneys that are damaged and people end up on dialysis, or infections from stasis of urine that's not getting out, or stones in the bladder, or bleeding. This is really what we're trying to avoid. This is more the exception than the rule. Most people get bothersome symptoms and quality of life issues, but it's important to realize this process can progress almost like looking at your face in a mirror and not recognizing you're aging. It happens so slowly. It can progress to the point where you can lose function in both the bladder and the kidney and get severe sequelae and complications that cannot be undone. And so that's what we're kind of really trying to avoid. Next slide. So this is another picture showing the same thing. Again, this is a sagittal section. If you cut me through my nose and move half my body aside, the furthest to the left is the cartoon above that shows the normal state of affairs with a nice thin-walled, healthy bladder and a channel running through the prostate. Underneath is the appearance of what it would look like when we look in with a telescope. You can see the black on the furthest to the left underneath picture. That's what we call the lumen, the opening, the channel going right into the bladder. There's plenty of room for the urine to run through, high flow, low pressure, low resistance. The next step over is a prostate. The one in the middle is the cartoon above. The prostate's getting a little bigger. You can see it's compressing the tube running through its center. The picture underneath in the middle is the cystoscopic or the telescope appearance. You can see you don't see much of that black space anymore. There's not much channel, but there's still a little bit of space. And then if you go furthest over to the right, you can see there's almost no space on the cartoon picture above. And furthest to the right below, we say these are kissing lateral lobes. The two sides of the prostate are so close together, they're almost touching. And there's very little room for the urine to get through. That bladder is going to be working overtime to get the urine out, and it won't be very successful in getting all of it out. Next slide. So as far as making the diagnosis of BPH or prostate enlargement, it's similar to any other medical condition. We start off by taking a history, asking about the onset of the symptoms and the severity of the symptoms and the degree of bother. And we examine the prostate with a finger, the way Dr. Boczko has referred to. The rectum is an organ that sits very close to the prostate, so we can feel the prostate, both for nodules that might suggest cancer, and we get a rough estimate of the size of the prostate on exam. There is a questionnaire that we often have you fill out that helps us calibrate the degree of bother from your symptoms, called an AUA symptom score, that we often use, and how much it bothers you. And then there's a number of specialized tests that we do, including looking in the bladder and measuring the bladder with ultrasound, and a functional study of the lower urinary tract. We measure how fast the urine comes out, either in a non-invasive way without catheters, or in a sort of more accurate way with small tubes. And this, again, helps us to calibrate the appropriate treatment to the specifics of everybody's anatomy and physiology and preferences. Next slide. It's also important to remember in the process of working up these symptoms of prostate enlargement that, you know, one of the things that they used to say in urology training is that the bladder is the vocal cord of the urinary tract. I always thought this was kind of a sort of a very wise or sagacious phrase, but it refers to the fact that the bladder it reacts the same way. When something goes wrong, it creates what we call LUTs, lower urinary tract symptoms. We talked about some of them: frequency of urination, urgency of urination, getting up at night to go to the bathroom, burning when you urinate, decreased force and caliber of the stream, starting and stopping, straining, incomplete emptying. These symptoms are somewhat stereotypic, and they don't really tell us what the problem is. Oftentimes it might mean prostate enlargement. It could also mean that you might have fallen down as a child or had a bad infection and developed scar tissue that narrowed the tube, the urethra, called a stricture. It could mean that just like a truck driver who's been sitting in his truck too long, you've gotten bacteria in the prostate and you have that inflammation or prostatitis that Dr. Boczko was talking about. It could mean that you have an infection in the bladder itself. Sometimes the first sign of a bladder cancer is urinary frequency and urgency, because the cancer itself incites an inflammatory response, and the bladder responds by creating the urgency and frequency. Sometimes it means there's a stone in the bladder, either one that passed from the kidneys or one that developed from a prostate that's blocking the flow of urine, leading to stasis of urine in the bladder. There's certain medicines that can create these symptoms. Frequently, we will see patients that get put on medicines to treat their sinus infection or their nasal congestion with decongestants and antihistamines, and they'll come in, they will be unable to urinate because those medicines cause contraction of the muscle in the prostate, or they paralyze the bladder. Many medicines that are used to treat mental health conditions can also have side effects on the lower urinary tract. And sometimes lower urinary tract symptoms, frequency, urgency, nocturia, other ones, can be the first sign of something like multiple sclerosis or another neurologic condition that may manifest itself for the first time as changes in the way you're urinating, and sometimes even bowel habits. So we have to keep in mind in the workup that not all that is alike is not the same. And prostate enlargement is very common. We mentioned it's ubiquitous. It happens sooner or later, but there's these other conditions. And just because we sometimes hear these horses' hoofs, we have to be aware that there could be a zebra around the corner at times. And we look into these things with our history and physical and specialized testing to kind of ferret that out. Next slide. So this slide is kind of the important point that I want to get across. You know, as we sometimes say, just because you're paranoid doesn't mean they're not out to get you. As the prostate gets bigger and causes blockage of urine, and it happens slowly, and you may not really notice it because it's happening slowly, we want to make sure, in everything else that we do, that you don't develop damage to the bladder, infection, bleeding, inability to get the urine out, failure of the bladder that results in lifelong need for catheterization, kidney failure that results in need for dialysis or kidney transplant. This silent BPH or silent prostatism, as this slide says, this is the real danger of untreated and undertreated BPH. Yes, we want to improve people's quality of life, but we want to make sure we don't miss this sequela where there's permanent damage that can't be undone that really is a problem. Next slide. So we're going to hand off to Dr. Boczko now. He's going to talk about some of the treatment options here, and then I'll come back and then we'll finish up and we'll take some time for some questions. You're up, Judd.
Okay, thanks. Okay, yeah, so everybody could keep on using the chat box to hit us with questions. We're just not going to interrupt in the middle to answer them, but we will try to get to all of them as much as we can at the end of the presentation. In terms of treatment options, as Dr. Blair said, the treatment of disease has to be customized. You know, everybody has different expectations or different desires. People are worried about different side effects. And it also depends on the degree of obstruction. And it's not just about obstruction, but like Dr. Blair said, it's also about the bladder, how the bladder is responding to the prostate. Is the bladder overactive or is it underactive? All these things go into an evaluation. That's why Dr. Blair mentioned there's that pretty thorough evaluation you have to do in order to really get to the bottom of it, to try not only to treat the disease, but the symptoms that people are complaining about. Next slide, please. Okay, so treatment options, we kind of divide them up into these different categories. So watchful waiting essentially means you're waiting. You're not using medicines, you're not doing procedures, you implement some diet changes. Medications, we'll go over. Minimally invasive therapy include Rezüm and Urolift. And then surgeries are either a laser TURP or what we call a bipolar TURP, an open prostatectomy, which is very rarely done these days. And like I said before, different treatments are appropriate for the different patients. So let's get into the next one. So that list is obviously going from the least invasive to the most invasive. And again, the key is to keep on mentioning different treatments are appropriate for different patients. Next slide, please. So watchful waiting, the advantage is you're not doing surgery, you're not doing procedures, you're not using medicines, you don't have any side effects. The disadvantage is you're generally not going to get a huge improvement in symptoms. Sometimes those diet changes will improve some frequency urgency issues, but it's certainly not treating an obstruction. And what Dr. Blair mentioned is really important, which is that when someone has an obstruction, it does not occur in a vacuum. It really puts damage and pressure on the bladder, not over days or weeks, but over months and years. The bladder has to strain and push to get the urine past that obstructive prostate. And the more the bladder pushes, the more the bladder undergoes changes. It sometimes loses elasticity, but there's a lot of wear and tear on the muscle, and then the bladder can get worse and worse and weaker, and there are some long-term medical ramifications as a result of that. Next slide, please. In terms of medical therapy, the main category is called alpha blockers. These are the trade names: Flomax, which is now called Chamsolocin, Uroxetrol, which is alpha-gocin, Hytrin, Cardura, Rapaflo, which is Silodosin. What alpha blockers do is they relax the muscles in the outer part of the prostate and soften up the prostate so it expands outwards. If you remember that diagram that we could go back to, but we'll just keep on this slide for now. The prostate grows outwards, and so the inside channel kind of opens up, and then the urine comes out better. Alpha blockers do have some side effects. They can cause, in 1% of people, lightheadedness or dizziness. They can change your ejaculation volume, not necessarily your erections or sense of ejaculation, but certainly when you ejaculate, it might be a blank ejaculate with nothing coming out. There are some recent studies that question maybe some long-term effect of alpha blockers, but it's not really definitive yet. Androgen suppression, the medicines are called Proscar or Avodart or finasteride or dutasteride. Those don't work as a targeted therapy. Like the alpha blockers work targeted on the prostate gland in terms of the muscle to soften it up and directly impact within 48 hours your urinary flow. The finasteride, dutasteride group of medicine work on the actual prostate gland in terms of size and tries to reduce the size sometimes by up to 20%. It's not targeted therapy, so sometimes it just reduces the growth on the outer aspect of the prostate, which doesn't necessarily measure up to the inside where the urine goes. They do have some hormonal potential side effects, including decreased libido, erectile dysfunction, breast tenderness or breast enlargement. Not a huge percentage, but it's about 5% of each of those side effects, so someone has to be aware of that. This category of medicine got bad press in about 21 years ago, where there was a study that came out that questioned maybe those medicines could potentially increase the risk of cancer. And basically that was just the newspapers jumping onto things way too quickly, not a surprise. And when they looked at the data more in depth, it actually showed that those medicines could actually reduce the risk of low-grade cancer. It doesn't do anything with high-grade, but it can reduce the incidence of low-grade cancer. It's one of the few medicines out there that can do that. And what it is just that people who develop prostate cancer and they're on that medicine might be more prone to have a higher grade, not because these medicines cause the higher grade, but just because it removes some of the lower grade cancers out there. And then last is phytotherapy, which is basically herbal supplements. So saw palmetto is the main one that's out there. Both Dr. Blair and I would say that supplements are a good supplement, but they're not a replacement for medicines or procedures. If someone really has an obstruction, saw palmetto is not going to take them out of obstruction. It's a good, safe supplement to use, and certainly you can use it as an adjunct to therapy. And if you get some benefit out of it, that's great. But I wouldn't, that's why it's called a supplement and not a replacement. Next slide. I spoke about this. I spoke more specifically about each medication, but in general, in terms of category of medications, the advantages are that no surgeries or procedures. You would get some symptom relief. Disadvantages include that these are lifelong therapies. When you stop the medicine, the obstruction comes back. I spoke about the potential side effects of the different medicines. Out-of-pocket costs are not as bad anymore because they're generally generic. They're not free, but they shouldn't be a high cost. Insufficient treatment efficacy is that medicines will only work to a certain degree. They are not going to cause you to reinvent the wheel. It's not going to all of a sudden make you urinate superbly, but it will give you some good efficacy and symptom relief and does help with the obstruction and will alleviate pressure on the bladder. Next slide. So in terms of procedures, the one that I'll start with, and then Dr. Blair will talk about the other office-based procedure, is called a prostatic urethral lift, or we call it a urolift. A urolift is an in-office-based procedure. It can be done under sedation anesthesia or local-based anesthesia, although sedation is certainly more comfortable. The main benefit of the urolift is it does preserve sexual function in terms of erections and specifically ejaculation. So if someone is disturbed when they're on the medicines, for example, in that they have absent ejaculate volume, they sometimes can switch off that medicine and do this, thereby regaining their ability to ejaculate. And so the ejaculation issue is not 0% on the urolift, but it's more like a placebo, like 1% or 2% risk. Or if people, this procedure is good for people who don't want to be on medicine or who don't tolerate the medicine and they're looking for an alternative and they don't want to go ahead and jump to surgery. The urolift is essentially immediately impactful because it's pushing the prostate tissue out of the way, so it doesn't take several weeks for it to work. You do get some burning on urination for a couple of days after the procedure. The slide says typically no catheter, but in general, we do leave a catheter in, but just overnight. It's the procedure that requires a catheter the least amount of time, but it makes the recovery process go much more smoothly when you do leave a catheter in overnight. Next slide. In terms of this is obviously a cartoon anatomy of what gets done. So you put a catheter, you put a scope through the urethra, and that's it in that urinary channel in between the prostatic lobes. And essentially what you do is you push the prostate tissue together. You compress the tissue, and then you use these implants to kind of smush it together and keep the tissue out of the way. And so the slide on the right is where you have the implant in, and basically it's stretching the tissue outward and compressing it, opening up the urinary channel. Next slide. Well, that's what the device looks like. The implant is on the left side, magnified. The implant is really small, basically a centimeter. And part of the implant is on the outside part of the prostate, and that basically keeps it in check. And then the inside implant is the part that pushes the tissue to the outside. I had been asked in the past about could the implants be removed. So they could be removed if someone has surgery. Like if they graduate to a TURP at some point in their life, you could remove it during the TURP. I've never seen, I don't think Dr. Blair, none of us have ever seen any implants loose in the urethra, but there are some study reports about that happening. Next slide. So again, it's an immediate impact. The picture on the right, the top picture is where you have those, what Dr. Blair mentioned, these kissing lobes or the lateral lobes of the prostate are kind of obstructing the urinary channel, and then you push the tissue out of the way, and then you see the black, which is the bladder, and then you create a channel. And that's what you're doing. Next slide. Dr. Blair, you're up.
So we're going to talk next about this procedure called Rezüm. But before we do, I want you to look at the slide right underneath the title where it says less invasive, more invasive. This is what we call the spectrum or the continuum here. And I want to emphasize something that Dr. Boczko said with this customizing of the treatment. You know, treating prostates is a lot like life. You don't always get to have your cake and eat it too. So at the far left of this continuum where it says less invasive and watchful waiting, you got the treatments that have the lowest risk, watchful waiting really doing nothing. They have the lowest risk, but they're also the least effective. And each incremental step over to the right, when you get to the green here, medications, you're getting to something that's more effective, but then medications sometimes have side effects. And then instead of one medicine, you can have two medicines. So you get more efficacy, more effectiveness, and more risk. And then the prostate lift, well, you know, you can get sometimes infection or bleeding or urinary retention. So more effective, much better than medicines or waiting, but more risk. Now we're over here on thermotherapies. These are treatments where they're more effective than the medicines and the Urolift and watchful waiting, but they're also, there's a little bit more risk and a little bit more downside associated with it. Again, you don't get your cake and you don't get to eat it too. So with the thermotherapies, they all have in common, you're kind of heating up the tissue and parboiling it, if you will. And once the tissue is parboiled on the inside, you wait for that tissue to slough off, like almost like a snake molting its skin or sloughing off your skin after you get a bad burn. And when that tissue sloughs off, it creates an opening. This Rezüm procedure is the newest and most modern of the thermotherapies, the other ones being microwave therapy and needle ablation. The Rezüm, we're big fans of it because instead of the microwave and the needle ablation, which kind of heat up the tissue, but there's a problem with the conductance of that heat energy where you don't remove much tissue and get that much benefit. The Rezüm has this much improved conductance because it uses steam. And the steam actually, it transfers the heat much better. The analogy I like to use is if you take a soda and you put it in the freezer, it takes 30 minutes to get cold. But if you take a soda and you put it in a ice bucket in the freezer with salt in it, it gets cold in about 10 minutes because there's more molecules cooling that soda down when you have that better conductance. So it's the same kind of thing with the Rezüm. It works much better than the older procedures that it's replaced, the microwave and the tuna. So if you know people that have had these other heat therapies like Thermatrix or transurethral needle ablation, they said, you know, it didn't really do much. The Rezüm is a different ballgame. So what are the advantages of the Rezüm? It's done in the office, and it literally takes about 5 minutes, which is nice. It can be done under sedation, but we really give you the same kind of anesthesia. So Dr. Boczko and I recommend, you know, the kind of anesthesia you get when you get a colonoscopy, kind of twilight, where you're out, you won't feel anything. It's paid for by most insurers. It has very few side effects, bleeding and infection being the most common. Now, unlike the Urolift, you do have to have a catheter with this procedure. So that's sort of a tough sell for some people. They don't want a tube in their penis, even though it's only in there for a couple of days. And then the other downside with the Rezüm, you don't get better instantaneously. At first, there's inflammation and swelling that has to dissipate. It's part of the inflammatory response. And that takes, 4 to 6 weeks for that to all calm down. And we like to say with the Rezüm, you kind of get better week to week more than day to day. But when you're a month and a half out, there's a 90% chance to be significantly better than you were on the medicines and not need them. And as you move over here on this continuum that we mentioned here, you're getting to treatments that are more durable. They last longer. These procedures are almost like giving the prostate a haircut. And the Rezüm is more like, given not quite a crew cut, but given a short haircut compared to, say, a trim for the Urolift and almost no haircut at all for the medications. Next slide. So this is a cartoon, anatomy cartoon showing how it's done. You can see on the left side, the steam is emitted from this catheter into the lateral lobes of the prostate. And it doesn't really happen in real time like this because, as I mentioned, it kind of parboils the tissue, which then sloughs off over the ensuing month and a half. But this gives you an idea of how it creates an opening that decreases the resistance and decreases the pressure that the bladder has to generate to get the urine through the narrow channel that results in all the symptoms improving when you're a couple months out. But it literally takes 5 minutes. We inject steam in precise locations in the prostate, depending upon the size of the prostate. That determines how many places we place the steam. And, we've been getting some really good results. This procedure has been around about 5 years now. And we have a pretty good track record and are very happy with the results. Next slide. It does literally take about 5 minutes. It's a few drops of water in the form of steam. It's very safe. Next slide. The procedure, I would say, I'm not sure I completely agree with this slide. The second line says that noticeable improvement in 3 weeks. Some people get that. Some of the bigger glands can really take a month and a half before you say, wow, I'm really urinating better with a stronger stream than I was before the procedure. Because as I mentioned, you tend to get inflammation before the tissue sloughs off. We mentioned that it can be done without general anesthesia. We don't recommend it. We recommend giving you some anesthesia. We have an anesthesiologist who comes to our office once a week to do that. As far as section, none of these procedures really affect the rigidity of erections. but some of them can make the semen go backwards into your bladder. With this particular procedure, you might not see as much semen come out of your penis when you ejaculate in about 10% of people. 90% of people preserve what we call anterograde ejaculation. This procedure has no impact on erections, as the other procedures don't, and the TURP tends to not affect erections. But this procedure and the next two procedures we're going to talk about, they can sometimes make the semen go backwards into your bladder. Incidentally, the medicines that Dr. Boczko talked about, the alpha blockers and the 5-alpha reductase inhibitors, can also do that. But with the medicines, it's temporary. If it happens with this procedure, it can be permanent. If you're trying to have kids, it can be a problem, but if you're done having kids, it's usually not a big deal. You can get back to your normal activities, but you can be worse for the first several days. So this can be a little misleading. And as we mentioned with the Rezüm procedure, you do need a catheter in your penis for 2 days. Next slide. So what are some of the advantages of a TURP? So now we're kind of moving over to all the way to the right to this, what we call gold standard procedure to treat prostate enlargement. TURP is an acronym that stands for transurethral resection of the prostate. This is a procedure that used to be the most widely performed procedure in the hospital. It was the #1 for many years before there were medicines to treat prostate enlargement. It's no longer #1, but it's still very common. And it is the, it's the gold standard. It's the treatment that we compare other treatments to. It removes the most tissue, gives you the biggest improvement in your flow rate, and it lasts the longest. This is the crew cut, if you will. The prostate stays open the longest before the prostate grows back, sometimes 10 years before you have to do something again. So those are some of the advantages. This advantage has to be done in the hospital. You have to spend the night. You have to have irrigation into the bladder because there's a higher bleeding risk, bigger risk of infection, small risk of injuring things. It absolutely requires a deep anesthesia. And, there's a small risk of injuring things and other side effects to be aware of with the TURP. But that's the TURP. Next slide. So the TURP is a surgical procedure. We're not cutting you open like a clam. It's all done with a telescope through your penis. And, you usually only spend a couple days in the hospital, or maybe sometimes 1 day in the hospital, but it is more invasive than the other treatments we've discussed so far. The TURP will cause you to have the semen go backwards into the bladder forever. And it won't affect erections, but you will get what we call retrograde ejaculation. There's very little risk of incontinence after a TURP. Sometimes you can be stuck with an overactive bladder. That's more of when you wait too long to do the TURP. You have to run to get to the bathroom before the surgery. You may still have to run afterwards. But the force and the caliber of the stream generally are reliably things that are going to improve after a TURP. Next slide. So we're going to, am I talking about laser TURP or you, Dr. Boczko? I can't remember.
Whichever one you want.
Okay, I'll keep going. I can't remember which one I was supposed to do this. So now we're going to talk about the laser TURP, which is one step away from the TURP. So again, on that continuum, it's not all the way to the right, but it's one step back. So the laser TURP is a safe and effective treatment for prostate enlargement. It has many of the benefits of the TURP, but the big advantage with the laser TURP is instead of scraping the tissue out with a wire that has electricity running through it that can have some bleeding risk, the TURP uses a laser, and the laser will vaporize the first layer of tissue in the prostate, meaning it turns the tissue, the carbon in the tissue, to carbon dioxide. It melts away in front of you. You can see the channel opening up. The deeper tissue, it coagulates or it cauterizes and prevents the blood vessels from bleeding. So people generally go home the same day, almost all the time when we do a laser TURP. It does take a little bit longer than a TURP. It takes about an hour, sometimes even a little bit longer. It can be often done in the outpatient setting. We have a minor operating suite at our office, and there's sometimes it's done in the hospital depending upon comorbidities, but it has the advantage compared to the TURP of being done as what we call an outpatient, where you go home the same day. And you can see the statement at the bottom. The American Urologic Association says that the symptom relief provided by a laser TURP is very comparable to a TURP. So even though we still say the TURP is the gold standard, well, the laser TURPs may be a very close silver standard to that gold standard. Next slide. I think Dr. Boczko is going to take over here and show some of the differences in the anatomy and the customization of the prostate. So I'll hand it off to you, Dr. Boczko.
Okay, thanks. So the pictures here are basically different perspectives or different situations you can find somebody's prostate in. So again, the big balloon organ is the bladder, and then urine goes from the bladder right through the prostate. So in picture A, if everybody can see it, you actually have, like what Dr. Blair had spoken about initially with the anatomy, that's actually, you could have a small prostate, but a full-blown obstruction. Why? Because it's not the lateral lobes, it's not those two tissue pieces kind of coming together, but you have this growth of prostate tissue into the bladder. It's called a median lobe, and it happens probably about 15% of men that they get a median lobe. And that acts as its own source of obstruction. So when the bladder is trying to empty the urine out, the urine goes from the bladder through that, or like above that hump of tissue, almost acts like a flat valve, a little mountain, and then it's got to go through the rest of the prostate. So picture A is just the median lobe. Picture B, there's no median lobe. You just have the lateral lobes. You see that hypertrophy tissue kind of coming together. Picture C is the combination, which is, of course, the worst kind of obstruction, where you have the lateral lobes blocking things up, and you have the median lobe growing into the bladder. So that's like a double whammy of an obstruction. Picture D is just a nice, normal-looking prostate and bladder. Yeah, that's good. So we can go to the next one. So just to follow up on the laser surgery that Dr. Blair had spoken about, so basically what you do is you use a laser to vaporize the tissue. It's done through a scope. There's no cutting. It's not like a TURP where you're actually using a wire, a U-shaped wire to cut into the prostate. You're vaporizing the tissue. It's almost like melting the tissue with the laser. In terms of anesthesia, we do have different lasers that are available. Again, you have to kind of tailor which laser makes sense for an individual, depending on how big their prostate is or their comorbidities. But there are lasers you can do under sedation anesthesia, and there are lasers they have to do in a hospital setting. Next slide. It should not cause erectile dysfunction. It will cause retrograde ejaculation, where again you have absent ejaculate. You do get some side effects, mostly burning on urination. You also get some extra urgency and frequency. That can last 3 to 4 weeks. Your bladder and the prostate, you know, when you're doing something to it to a surgical extent, you can't expect there to be no side effects after that kind of surgery or that kind of procedure. So you do have 3 to 4 weeks of a lot of irritative urinary issues. The most significant side risk we always caution people on when it comes to the laser surgery, it could happen even in the non-laser surgery, is something called a bladder neck contracture or urethral stricture, which is scar tissue formation. So, you know, if you had a little, I always like to say that if you have a mole in your hand and you lasered it or you slipped it, you get a little bit of a scar. You know, some people, unfortunately, they don't scar down the right way. And instead of having a nice thin scar, you can get this very thick scar. And so you can get a thick scar in the prostate when you go ahead and do surgery. And if that happens, the scar itself growing big enough can act like an obstruction to the bladder, and then you have to go in and do another procedure to open up that scar. So it's a low risk, but it's definitely a risk with the surgical procedures, whether it's a TURP or a laser TURP. Next slide. Again, laser procedure generally is outpatient. You get to go home the same day of the procedure. Usually you have to avoid kind of core exercises, sit-ups, push-ups, bike riding, things like that for a few days or usually even for a few weeks. You do have a catheter in for 2 days. It'll be certainly uncomfortable. Once the catheter comes out, you can return to regular daily activities as long as it's not strenuous. But you will have, again, irritative urinary issues for several weeks afterwards. In terms of symptom improvement, you'll have a much better flow right away. It's not something we have to wait a couple of weeks for that to occur. Next slide. So does this work, the video?
Yes, bear with me. I'm just going to switch my screen so that we can play this video. Sorry, everybody, bear with me one more second while I find it.
Okay. Can people hear me?
Yep.
Yep.
Okay. So this is a laser. This is a case that we did in the office setting under sedation anesthesia, like a colonoscopy. And essentially, you can see that the right and left part of the prostate was coming together. And this is the laser vaporizing the tissue. So you go back and forth on the tissue, and you can see it kind of just starts to melt open. You don't see a lot of bleeding. That's one of the advantages of the laser over the non-laser procedure. And you just have to kind of go very carefully. You go back and forth. You go from the area of the bladder towards the, what we call the apex of the prostate, which is the back form of the prostate. And you can see literally it just melts with the laser. Now, when you do a non-laser, if you can imagine just that same tissue, instead of lasering and vaporizing it, you go in with a U-shaped wire, and they call it the roto-rooter, which is where you go in and basically scoop the tissue out. But you can really see the channel opening up by doing this. This is the procedure. In terms of the length of time of the procedure, it does depend on how large the prostate is, how obstructive it is. There's not zero bleeding risk, but in general, again, it's less bleeding than a surgical TURP. I don't know if we could fast forward towards, or just we'll keep it going. I guess it's another 30 seconds or so. So this is the glandular tissue of the prostate, and you can see like the back part is still some tissue growing in. The black part in the front is the bladder itself. That's the procedure. It's not anything more than that. Let's go back to the slides, CR, if that's possible.
Yep. Can you all see the slides now?
Yes.
Perfect.
In terms of insurance coverage, sometimes that's a little tricky. The surgical procedures of the TURP and the laser TURP, those are always covered by insurance. Urolift and Rezüm are not always covered, unfortunately. A lot of insurances do cover it, but not everyone. Like we know for sure, like Blue Cross generally does not cover Urolift and Rezüm. Don't ask us why, we don't know. You could fight with insurance as much as you want, but it's out of our hands. Next slide. In terms of am I eligible for either treatment, so you're always eligible for treatment. And certainly, again, if you're on medicines, you're not happy with the medicine, either because it's not working well, you have side effects, you don't tolerate it. There's some people who don't want foreign substances and medicines for lifelong therapy, or medicines are working, but they're not quite working to the fullest extent, and you want a little bit of extra help. So anybody in that category certainly would be a candidate for any of these therapies. Next slide. How much experience do we have? So at one point, we were the largest volume of cases in Westchester and Fairfield County. Our laser volume has certainly decreased with the increase of cases such as Rezum and Urolift that Dr. Blair mentioned. We've been doing that for about 5 years. We were actually the first in Westchester to offer it. We are quite experienced. We're considered as advisors for other physicians to learn from us. Next slide. So consultation with the urologist is always important. Doesn't have to be us, it could be with your normal urologist. But, you know, if people ask about symptoms and therapies, you really got to tailor the treatment to the individual. Even what Dr. Blair had mentioned before about anatomy, there are other diseases out there that can mimic an enlarged prostate. It could be an overactive bladder, it could be bladder stones, it could be bladder cancer, it could be scar tissue. These things all have to be looked at in terms of overall diagnoses. And once you figure out what's going on and you narrow it down to BPH and enlarged prostate, then you have to see again what degree of obstruction is there, how much bladder weakness, overactive, underactive bladder, and you put that all together and you know, you make a team decision with you and your patient. Next slide. Okay, so let's get to the chat box questions. Dr. Blair, do you see it, or do you want me to read them out?
Let me find a good one. Let's see. I have one here. Does ED occur after a TURP, and will Viagra solve this? Do you want to take that one, Dr. Boczko?
So a TURP does have a slight risk of erectile dysfunction. There's something called bipolar energy, which we generally use for our TURPs, which is where the energy using for the TURP is really localized to in that wire itself and doesn't have as much of a spreading effect. But there is technically a risk, maybe 1%, 2%. Some people even think 4% does some amount of erectile dysfunction. If it occurs, if erectile dysfunction occurs with anything that's going on, it could be high blood pressure, it could be cholesterol issues, yes, Viagra generally would increase the blood flow to the penis and help with erectile dysfunction. Dr. Blair, there's one over here that says, is there a treatment for minor leakage that follows urination? It's one of the earlier questions. You want to try that?
Yeah, you know, there's something we use the fancy term of post-void dribbling. Post-void dribbling is a common symptom of prostate enlargement in general that's kind of undertreated. And a lot of times it's a sign that you just need to get a little more aggressive. Remember we talked about that continuum or that armamentarium of treatment. You're probably a little too far over to the left. If you have prostate enlargement, you're not on medicines. Usually the first step, we move one step over to get you on medicines. If you're on one medicine, you got a lot of post-void dribbling. Sometimes we should try what we call combination, or two medicines together. Those two classes are better than either one alone. If you're on medicines, then it might be time to think about, you know, one of the minimally invasive procedures. Or if you don't want a procedure, you know, there are some people that with post-void dribbling, it doesn't bother them so much. When they're done urinating, they'll stand at the bathroom and sing the national anthem, which is another solution. So yes, there's a lot of things that we can do, but it's usually a sign that your prostate, your BPH is undertreated. Let's see what else we got.
I just want to follow up on that. So I do always generally point out to patients that you could help with BPH. The post-void dribbling does not necessarily get better. It's something that kind of progresses with age, and more often than not, the best therapy, if it's not associated with other BPH-like symptoms, someone could have just post-void dribbling. They don't have any other symptoms of an enlarged prostate. You know, doing prostate therapy or medicines will not necessarily help the post-void dribbling. It's more behavioral therapy. Unfortunately, you just can't be in a rush to zip up.
Yeah, national
the
anthem.
question here, I want to jump on this question, which is, will taking testosterone pills help? So I want to be very, very specific about that, which is testosterone pills will absolutely not help BPH, but it actually does the opposite. Testosterone pills will cause the prostate to grow even more. So it progresses BPH. And testosterone pills, when you're on it, you have to be followed very carefully when you're on testosterone, because it doesn't cause prostate cancer, but if someone has prostate cancer and they're on testosterone, it could cause the cancer to progress as well. So when we see people on testosterone, whether it's injection therapy, patches, gels, there's a new nasal gel that really works well without as many side effects. But regardless, you need follow-up labs. You need to be followed carefully with urine tests to make sure that things are not progressing and getting worse while on testosterone.
There's another question here that says, prostatic artery embolization, is it effective? You want me to take it? Do you want to take it?
Either one, you can take it.
Okay, I mean, I would say that it's something new. It's a procedure where the arteries that go to the prostate are cannulated with a small wire that's placed through your groin and sort of feathered up to the arteries that go to the prostate, and usually metal coils are released to block off the blood supply to the prostate. And it's something that's kind of new, and it certainly is not that invasive, but the results have been generally not so effective, and to the point that I think most urologists would say it's used in the setting where someone is too sick or has too many medical problems to undergo a more conventional therapy. Do you agree, Judd? Or?
Yeah, I agree. Prostatic artery embolization, this PAE, there's really a lot of poor studies on it. There's not a lot of great studies on it. We usually, if someone recommends it, more often than not, for people who are not candidates because of surgical comorbidities, that they don't want surgery or can't undergo surgery. And more often than not, it really was looked at for people who had uncontrollable and recurrent bleeding from the prostate. And by doing the embolization, it decreases the bleeding risk. But in terms of urination, it's, you know, the jury's still out. It's very specialized. And I think there are a lot of criteria that don't fit most people to even see if they would be a candidate. That paragraph also had a question about aquablation. So that is actually not even an insurance-approved procedure. It is FDA-approved, but there's no insurance code for it, so there's not a lot of info out there. From the studies, I will tell you that the efficacy is equivalent maybe to a laser TURP, meaning they're trying to match the standards of a laser TURP or a TURP. Question whether they can get to that amount, but it's still needed to be done in a hospital under general anesthesia. So the question is what would you be gaining if you're already going to be in the hospital and you're already getting general anesthesia? What are you gaining by thinking about doing alcohol ablation as opposed to a TURP or a laser TURP where you have years of studies and safety data and it's more pinpoint? So right now there's not even an insurance code for it, so the jury, again, would certainly still be out for that.
There's a question here that says, are the ejaculation issues of Flomax dangerous? And are there other, I guess, other alpha blockers that don't cause this side effect? You want to take it?
So, sure. In terms of danger, no. The ejaculation, if it goes into bladder, you end up just urinating it out. There's no harm done, doesn't cause infections. It's more of a, you know, a personal, in some people, it just bothers people to not be able to ejaculate fluid out. Spouses should know it doesn't mean the person's any less excited or anything like that. They should know it's just a side effect of a medicine or of a surgical procedure.
There's another question here that says, what if the prostate isn't enlarged, but I still have to urinate frequently? I would say for this that, you know, we didn't talk so much about this. One is that you could have a small prostate that's growing inward. That I think Dr. Boczko showed one of those in the picture that might need to be treated because it's still obstructive. But the other thing is that urinary symptoms are not solely a function of what's going on with the prostate. There's also the bladder and the sphincters that are involved in the urinating. And, you know, if you're having urinary frequency, you could have a problem with not relaxing your sphincter properly or a bladder that has bladder dysfunction. And so those are things that we would, again, ferret out in the history and physical exam and specialized testing. And, you know, there's certainly treatments for, you know, dysfunctional voiding and bladder dysfunction and dyssynergia of the sphincter and other causes of urinary frequency that are not the result of prostatic obstruction. But that's something that it's not really what the talk is about tonight, but certainly, yes, there are urologic conditions that have treatments. Would you add anything to that, Dr. Boczko?
No, I think you got that. There are some diet questions. In terms of diets, I had mentioned before when we started, there are certain dietary products that could stimulate the bladder and cause worsening urgency and frequency. So things like alcohol, caffeine, whether that's caffeinated coffee, soda, tea, you name it. But alcohol, caffeine, green tea, black tea, cranberry juice, spicy foods, and dark chocolate. Very common products, a lot of, quote, healthy products, but all those do stimulate the bladder. Dr. Blair, there's a couple of questions about evaluation. Someone's asking about ultrasound. Someone's asking about, you know, how do you know you have an enlarged prostate? How do you know there's bladder hypertrophy? I mean, there are a bunch of questions about, like, how do you figure things out? So maybe that was some of the topics you had spoken about before. You want to try to reiterate that?
Yeah, you know, I think that, you know, what we were saying before about every patient being unique, we are going to not only tailor the treatments, but even the diagnostic workup is going to be tailored to the specific patient complaints and concerns in the history. And so, you know, sometimes if someone seems like the problem is prostate enlargement and we're trying to solve the problem with the least invasive diagnostic workup, maybe we would try medicines. If someone didn't respond to the medicines, we might take a look at what their flow rate is and how much urine they're leaving behind. When they're done urinating, the amount of urine that's left behind, what we call the post-void residual, gives us an indirect idea of whether or not there could be obstruction. If we still are not able to answer the question of where the primary problem is it a bladder problem, is it a prostate problem, then we start to employ the anatomic studies of things like cystoscopy and more invasive testing called urodynamics. But yeah, we have a lot of tools in urology to get to the bottom of it. I like to say that we have tools where nothing can hide from us. We're going to know what the problem is. Now, sometimes we don't want to go right to those tools. If we can figure it out without using some of those tools, then we'll figure it out just by, you know, physical exam and history taking. But we have a lot of specialized testing that can kind of get us to nail down the diagnosis, as we like to say. I see a question here that says, can you have cancer with a low PSA and not have an enlarged prostate on examination? So this really wasn't so much a talk on prostate cancer, but with prostate cancer, I would say yes. You know, about 10% of prostate cancer is found in the setting of a normal PSA with an abnormality on digital rectal exam, which is why we are examining a lot of prostates with our fingers in urology. And sometimes the PSA can be relatively low, but the rate of increase could be concerning. You know, eventually when the PSA starts to follow, or the dynamics of the PSA follow this graph of what we call exponential growth, that's really a sign that you probably have prostate cancer, and we really need to nail down that diagnosis. So certainly, yes, you can have a low PSA and have prostate cancer. And when you come in with urinary symptoms, in addition to really establishing the cause of your urinary symptoms, whether it's BPH, bladder dysfunction, dyssynergia of the sphincters, infection, prostatitis, we're also going to be assessing you for prostate cancer risk. What else?
There are two quick questions on Urolift I could just answer. One, someone asked if they're permanent. So yes, the implants are permanent, although again, if someone ever has a TURP down the road, you could remove them as part of the TURP. And then as far as I know, they don't ring alarms at the airport. You know, there are a lot of medical implants out there head to toe that people have, and they're not supposed to be able to ring most of the time in the airport. I do know I actually had a patient one time that was allergic to iron, and then I found out that when looking into it, that if you're allergic to iron, you can't have the implant. But and then in terms of, someone had asked about the video, I think Ciara is supposed to email out a link to anybody who wants a review of this, that they could go ahead and watch the video at a later date. How do you make a distinction between BPH and prostatitis?
So as Dr. Boczko was saying in the first part of the speech, you know, prostatitis is something that often comes on more rapidly than BPH, which is sort of a more indolent, slow process. And prostatitis often has some of these symptoms like pain in the perineum, behind the testicles, or in the penis, or in the testicles, or in front of the penis in the suprapubic region. Some people with prostatitis can have pain with ejaculation. It's often associated with sitting for long periods of time, and constipation and dehydration. And it's going to get better oftentimes with a short course if it's bacterial prostatitis, which Dr. Boczko was saying is the exception. The antibiotics will make it better. If it's a inflammatory process, often anti-inflammatories will make it better. BPH is a process that occurs slowly over decades, and it is relentless, and then it just gets worse and worse and worse over the years. So prostatitis kind of comes on quick, and there's certain very specific symptoms that are associated with it, and it usually gets better. BPH, you know, we kind of control it, but it's getting worse unless we do one of these more aggressive things.
So I think we're basically at the end, I think, of the Zoom maximum amount. I think we've been on Zoom for an hour plus. So I would just say, we want to thank everybody for coming out tonight and virtually watching us. You know, hopefully this answers a lot of questions for people, and at least does something for an education.
And we also want to thank Ciara for setting this up and holding our hands with the technology. I know I'm not the best Zoomer in the world, and you know, we appreciate all that help.
Well, thank you both, Dr. Blair and Dr. Boczko. I know we're getting a lot of comments that this was a very informative presentation, so thank you very much. I also just, again, want to reiterate, I will be emailing out the slides as well as the URL to that video tomorrow, so everybody can refer back to those. And thank you for everybody who joined this evening. I hope everybody stays safe and has a wonderful evening.
Good night, everybody.
Night.